Great. I hope everyone can hear me. First of all, thanks very much, Lewis, for joining us. You've magically changed into another room for the reasons that I know. It's great. Thank you so much for that talk. That was really masterful and really picked up a lot of the issues that we want to get into. First of all, I want to introduce, and you can see the pictures there looking very senior and very important, my co-panelists that you'll see from the program. And I think it's really important we have a nice mix with Edith from Nigeria and Sub-Saharan Africa and the University of Jos, and also our colleagues who are from Egypt. So first of all, I want to open it up to any questions for Lewis. We have a bit more time because we haven't really got much in the way of other discussions. But personally, for me, for end-stage liver disease, I think this is much the most important topic. I don't really think that talking about the magic unicorn of transplantation and other issues are relevant. So, Lewis, can I ask you a question first while some of my colleagues are getting themselves unmuted and ready? Why do you think that the African epidemic of HCC is not being recognized in any of the guidelines to date? So I sit very much with you in the frustrations of not having any real sophistication of the understanding of HCC in African patients that are reflected in either the global or any other guidelines.
Thanks, Kaushan, and thanks so much to the other co-discussants in this group, and really to the entire COLDA organization for organizing this meeting. I think one of the challenges is the lack of data. And I think it's really important for us as a community to work together to ensure that there is increased awareness on a global scale of the impact of this disease in Africa. I think our experience has been, as we've had conversations with ministries of health, with policymakers, with international organizations that are focused on healthcare in terms of the global burdens of disease, that this is really just one of the hidden epidemics in many of our countries. Patients are diagnosed quietly, often in rural areas. They present without a lot of, in a sense, fanfare. They are too sick often at the time they present to form anything like an advocacy group of substance, and they die quietly and very quickly.
Okay, thank you very much. I'm going to keep things going along because we have actually quite a lot of comments and questions coming in now that I've finally figured out how to get that working. So before I go to that, can I welcome Edith to the panelists and really value what's your perspective of what you just heard in the last 25 minutes? How does it feel on the ground? How does it feel for you? This is your area of expertise.
Yeah, it's pretty much the same actually, because when you talk about the late onset, that presentation of patients is so late. Most of the patients that we see, nothing can be done by the time they present. And then we've put this together. In fact, the mortality in my area of Nigeria, where I work, is 2.5 months, not even up to the 4 months, 3 months. That is a mortality between the time of mortality between diagnosis and death. So pretty much patients just present just before they die. So the situation is really there, but with a lot of education that has been going on in the community and everywhere, the Society for Gastroenterology and Hepatology in Nigeria and with the government has really are working together to really spread the message so that people come in, so that we do a lot of screening. The hope is that in future, patients will start coming early, but that's the same thing. And I think the story is the same pretty much all of Africa. I mean, sub-Saharan Africa. That's the thing.
Okay, thank you. Can I bring in and welcome Professor Ashraf from Cairo University, who's another expert in HCC, where we are overwhelmed with the expertise. I'm the one dropping the expertise for the team here. What's your perspective from that data you've heard? Is this reflective of your practice?
Yes, thank you very much, Dr. Kush, and I'm really welcome Professor Lewis and Professor Dr. Okiki. It's my pleasure to join this, and it was an outstanding presentation from Dr. Lewis. And thank you. It was my question. Your question, Dr. Kosh, was my question to Professor Dr. Lewis, the need of protocols and guidelines for treatment and management of liver cancer in Africa. Liver cancer is a major problem in Africa. And we had some conversation with Dr. Lewis in Boston a few months ago about the need of an African guidelines, and the problem, as he said, the lack of meta-analysis and the lack of data. So the problem in our African continent is we need more and more, encourage more and more research in the field of liver cancer, in the field of diagnosis, in the field of early detection and treatment. And we have in our country really a good example in approaching the problem of liver cancer, the availability of different kinds of treatment options, and treat the major risk factors of liver cancer. As Dr. Lewis said, hepatitis C virus was the major risk factor of hepatocellular carcinoma in our country, and by now it was a past problem. By now we could implement a program of mass treatment, and next we implemented a program for screening every person in Egypt of having hepatitis C virus, providing the treatment for free. So by now we don't have that problem again. And of course, it's considered to be a primary prevention of liver cancer. I think it's just an example of how we can approach a problem such in such a case in Egypt, a major problem like hepatitis C virus, a major problem, a major risk factor for hepatocellular carcinoma. So it's just an example for how we can approach this. So
great. So I'm going to come across, because actually we have a lot of questions coming through. So it's really precipitated a lot of discussion. I'm really glad, and I thank all my colleagues on the COLDA organizing committee that we have given time. And this is really focused on HCC, I think, in the majority. So quick questions from me, and then reflecting some of the questions that I'm seeing on the chat. And thank you all for those questions. Please keep them coming. So number one, Professor Ashraf, do you see in your HCC practice, what do you feel your median survival is now with your Egyptian patients? Is it improving? Do you have access to all therapies? Is diagnosis by and large happening before the presentation of HCC? Can you just give me a minute on that before we move on?
Yes, in the last few years, we have implemented the multidisciplinary approach for hepatocellular carcinoma. And this, of course, has a positive impact on the early diagnosis and the treatment of hepatocellular carcinoma. We have tertiary centers along Egypt, and through these centers, we can see patients with liver cancer, and we provide most of the management options for hepatocellular carcinoma are by now available in our country, even for liver transplantation, resection, percutaneous ablation, and all other options are available. So this has has a positive impact on the survival, the overall survival, of course, of liver cancer. However, the problem is we need some education for the patients for approaching the clinician for regular follow-up for every patient having chronic liver disease. This is what we need in our country, because most of our cases, unfortunately, coming in the intermediate stage, maybe with port of invasion. However, all options like TARE, transarterial radioembolization, is also available. Even the new immune therapy now is by now available. However, it's very expensive, and I think it will need a lot of time to be implemented in our country.
Great. Let me come to Edith, and then I'm going to come back to Lewis because there are some questions from your presentation. You're very chatty, Professor Ashraf. We have a lot of questions coming through, so this is lovely. I want to keep this interactive. So Edith, what availability of therapies do you have, or is it really a moot question because of the late presentation and the lack of diagnosis in these patients when they come to you?
Yes. Honestly, we do not have any of those things. Let's see. When it comes to resection, maybe 2 or 3 hospitals in the country can offer that. For ablation, TACE, and all the others, we really do not have it. And majority of our patients come in late anyway. Now, so the patients that come in, so all we are really able to do is to give them the chemotherapy. Sorafenib is available, but I just listened to Professor Arab saying that the country, that they are treated free. 95% or 98% of our patients pay for their drugs. So, and then unfortunately, most of the patients are the poor ones, so they are unable to afford these drugs. So patients pay for the drugs. So most of our patients, all we do is just give them sorafenib and then the palliative care. So that is all we are able to offer.
Okay, thank you very much. I'm going to come back to Lewis here because he's being very patient. So number one, some questions from your talk. And really, I guess we're saying as a group for the rest of the COLDA kind of team, always trying to put liver disease onto the sort of societal and a sort of healthcare environment as a major issue. And really, HCC is kind of where the kind of rubber hits the road in liver disease. Do you think the data from your original presentation, do you think that data is improving, or the capturing or the diagnosis is improving in the time you've been involved and interested with your consortium, Lewis?
I think actually, if we look back over, I would say, the last 10 to 15 years, we've made substantial progress with the general medical community. Within our countries, I think we're making increasing progress with ministries of health. I think it's been really transformative, having the president of Egypt be president of the Africa Union was really helpful because of the efforts within Egypt and the ability to make that. I think to bring that to the awareness of other national leaders across the continent. I think it's remarkable. 10 or 15 years ago, we had substantial difficulty, for example, convincing the Clinton Health Access Initiative that hepatitis was something that they should have a focus on. And we now have programs that are being led by the Clinton Health Access Initiative to collaborate with countries to address hepatitis C in Africa, for example. So I think we've made a lot of progress, but we still have a long way to go to reach care for individual patients.
Okay, I'm going to keep us moving on because there are questions I want to come to. So this will go to the time that is allotted. So a very nice question from one of our attendees, BC, who I remember meeting in one of our meetings, really saying, again, this this incessant neglect of liver diseases, and obviously now with other viruses such as COVID-19. So just a shout out for the next session, which I think will be very interesting on COVID and liver disease. How do we put sort of liver disease and liver viruses that are driving in this environment morbidity and mortality a little bit more on the agenda? My only comment is, number one, I think we're not very good at surveillance everywhere. It's not just in Africa. I think there's data I've seen from the US, Lewis, that generic providers of gastroenterology have actually quite poor, and so we even sometimes even in the area of Kings, but likewise how this in this continued concern of how do we put pressure on governments and healthcare providers and to try and have this earlier diagnosis. So the reason I wanted to talk about kind of the higher end options was really to draw a line under them and push them away. So a couple of questions about coffee. That I think some of our attendees just wanted some more clarity about the coffee consumption comment you made, Lewis. And then there are some other nice questions coming through, and I'm desperately trying to find the question that came from Jeff Dusheko as well. So over to you, Lewis, and then I'm going to come back to my other panelists.
I think just very briefly on the coffee, there's now a fairly substantial amount of epidemiologic evidence that suggests that coffee is preventive for chronic liver disease broadly, and reduces progression of chronic liver disease. And I think that's to the point where for the first time, we actually have the European Association for the Study of Liver Disease that has actually included in its guideline for HCC a recommendation that people with chronic liver disease should use coffee. The recommendation is basically for a minimum of 2 cups a day. And that appears to have very strong epidemiologic evidence for efficacy in reducing progression of chronic liver disease. I don't think that gets us away from all the other things we need to do to reduce risks of chronic liver disease. You don't want to continue alcohol use and be drinking coffee and think that will help, for example.
So Lewis, you're psychic, because I just wanted to then again, just for our attendees, just to really highlight the other comorbidities that need to be addressed, that coffee is not going to help us overcome those. And certainly I wanted to come back to Ashraf from his perspective. The obesity issue in Egypt is a very significant issue. Do you think that's now continuing to drive and build the sort of burden of HCC that you're seeing? Certainly, colleagues such as European colleagues and colleagues at King's, most of what we see now is starting to move, even though there's quite a big proportion still of viral hepatitis. We're seeing more and more NASH-related HCC. Is this what you're seeing in your practice?
Yes, thank you very much for this question. Actually, after the control of the problem of hepatitis and hepatocellular carcinoma in our country, by now it's the upcoming danger is the obesity, NAFLD, and NASH. We are now seeing, of course, the obesity and NAFLD are one of the major health problem in our country, and we start to see a lot of liver cancer on top of NAFLD and NASH. I think there will be a shift from the hepatitis risk factor in the coming few years from hepatitis B and or C as risk factors of hepatocellular carcinoma to NAFLD and NASH as a major risk factor of hepatocellular carcinoma in our country and in other countries, also in North Africa and maybe in Europe and in the States as well. So by now, we start to, after finishing screening patients of hepatocellular carcinoma, we shift screening for hypertension and overweight for all populations. And patients proven to have an overweight problem, we've start diet, consult a dietitian, and so on.
Great. I want to come back to Edith. Just again, I apologize for firing off questions. There are many questions coming that I'm going to kind of focus on. Edith, do you see any patients with HCC in your practice that don't have hepatitis B, that have, say, alcohol or NASH or is it just only as comorbidities that you're seeing your HCC population?
No, we see patients with hepatitis B, hepatitis C, alcohol, but in most cases, even our patients who have hepatitis B we have a major alcohol issue as well. So most patients, they are comorbidities. Well, in the area of NAFL and all that, NAFLD, we're beginning to look in that direction because obesity is slowly showing up, and there's really an epidemic of type 2 diabetes. So we're beginning to look in that direction, and the expectation is that patients will begin to see patients that will come in, that will present from that, but that's not a problem at the moment. So now our major cases are Hep B, but we also have B, C co-infection, C, and then alcohol. Alcohol is also quite important.
Okay, can I come back to Lewis, because we've got some questions there. You're being very brilliant as panelists. There was a question that came in about, and I can help you if it would be a good discussion, is really now refocusing on the different genotypes of hepatitis B. Do you think we've really teased out the understanding of the different preponderances of hepatitis B genotypes that are more predominant in sub-Saharan Africa, particularly from the data you've shown, in comparison to, say, Pan-Pacific Asia with the different genotypes that we see that are predominantly, A and B? I'm still unhappy about the lack of data that really pulls us in, because I noticed you still talked about aflatoxin, which to me is maybe a touch more historical from the data than it is in reality. What are your comments about this area?
No, I think that there's a lot to be learned still for us to really gain a complete grasp of what we are facing. And I think much of what we do is based on data from Asia. And it's important that we figure out ways to collaborate to improve our understanding of what's happening in Africa. So in Western Africa, for example, and in some parts of sort of western parts of Central Africa, we have this preponderance of genotype E, for example. And there's questions related to what the risk is and how much genotype E contributes to this risk of the early onset of hepatocellular carcinoma. There's some suggestions that genotype E perhaps is more easily transmitted horizontally as well. And that some of what we see in terms of transmission after birth is related to genotype as well. Professor Kramvis mentioned yesterday, for example, the importance of genotype A1 and the fact that in Southern Africa and along the east coast of Africa, we see A1 also contributing to transmission at relatively low viral loads. And so there's, I think, a lot to be learned still. And I think the other thing is figuring out how we determine who should be treated for hepatitis B in order to reduce HCC.
You're truly psychic. That was my next area I was going into. So lots of questions, and I'm still waiting for some questions from Wendy Spearman here. So I really want to go back, and we've clearly kicked the tires of this over the last couple of days. How do we, specifically improve testing for hepatitis B as a point of contact? This is something that Jeff and I have discussed on numerous occasions with other colleagues. How do you think we can step up with regard to point of care or early testing for fibrosis to identify those who have cirrhosis? And then obviously it's the WHO recommendations to try and increase the use of nuke therapy, which we clearly know is very effective in decreasing but not abrogating the risk of HCC development in hepatitis B alone. What are your thoughts around those horribly large questions? Can I come to Edith first of all? How do you feel we should really do this? We've talked a lot about this at the COLDA meetings over the last 2 years.
Well, what we propose to do is to improve screening. It's to,
okay.
Because if we can improve screening and be able to make, to test and confirm that these patients have some fibrosis and institute treatment early enough, then we will definitely get somewhere. But so the major thing is to get to the patient. How do we find them? So I think community screening, making sure that, because in many places, what is now done is that you make sure you put in screening, and the antenatal clinics, in schools, in, even during campaigns, go to the marketplaces and then churches, mosques, and things. So once we are able to improve screening and get the patients to a point where we can now make the diagnosis and make institute treatment, it will definitely improve the numbers. So I think.
Let me ask another question, and this is again for you, because I work in South London. It's sunny, it's Saturday, but I also still see, and we need to be very clear about this. We see every 4 months or so, again, stereotypically, a young male patient from sub-Saharan Africa, originally, who presents with very aggressive HCC in that age of 35 to 45. So, and again, those patients don't know their diagnosis, are presenting with that diagnosis. So this is not an issue that's just predominant to this constituency. How do you think education around other viruses apart from HIV is changing to benefit the populations to help that screening, or is it still really traditionally stuck with HIV?
Well, yes, it's still majorly HIV, but what we are now doing is to make sure we attach the screening for HBV and now HCV to all HIV screening centers, because now that it is clear that every nook and corner has centers for screening for HIV. And then if things can happen in such a way that the screening for HBV, HCV will also be offered free, just like HIV, it will improve the outcome. So that is what
Okay, I feel very bad because I've got some very important questions that I'm cutting you off for. We've only got 10 minutes left. I need to still cover a couple of areas. So Wendy, thank you so much for your comments. It's talking about access to ultrasounds in the community and the role of centralized reporting, but obviously also the idea of point of care testing. Again, we talked about for Hep B, HCV, and fibrosis assessment, and the suggestion from Wendy that an APRI score of greater than 2 seems to underestimate cirrhosis. And I think this comes back to a very sensible comment, and I think Lewis made this comment right from the bat, which is really the mission statement of this meeting, which is really putting liver disease in Africa on the agenda at all levels. So John is asking, well, with early onset of HCC, and I don't think we've teased out the drivers of that early onset or higher risk, do we think, or should we just discard the recommendations from ASLD, EASL, APASL? Be very careful, because I was one of the panelists for the EASL recommendations. So what do you think? Because I don't think they serve African patients and this discussion well in my book. Can I come to you, Professor Ashraf, first of all, on that horrible question?
Actually, I need to focus your question, please, again, if you don't mind.
Do you think the guidance, guidance that is not generated from populations that are either Egyptian or sub-Saharan Africa is really relevant in any setting, whether it's surveillance or for this discussion, HPV treatment initiation? Do you think, the push is really, we have to have our own guidelines, we have to generate the data? What do you feel about that?
This is a crucial question, actually. And the main obstacle for putting any acceptable guidelines is the availability of meta-analysis and the availability of valid data. This is the point. In our country, unfortunately, the data, the meta-analysis, the data is not so much available. So what we are now doing in our country is to improve the international publication, to improve the high quality data, so as we can use it for putting the guidelines in the field of hepatitis B, hepatocellular carcinoma, and other major health problem in our country. And
I'm going to cut you off there because we're running out of time. Edith, do you have a comment about my horrible question about essentially EASL and ASLD guidelines may not serve the constituency and the patient populations that we have? If we get to a world where our point of care testing is better, should we not just be much more aggressive about initiating therapy given the risks and the dynamic that we see in your practice?
Yes. One thing I have to say is that we have actually seen that our patients develop HCC with very low viral loads. So I think we cannot, it does not serve us very well. Like the guidelines that are given for treatment for HPV and HCP. So we need to attack our patients earlier. And then the screening too, from the data shown that our patients present about a decade, they present with HCC a decade earlier than other people. So the screening for Africans should actually, we've shown from the data that Professor Lewis showed, it was shown that if we can drop the age to about 30, 40, over 70% of the cancer patients will be picked up early enough for treatment, early enough for something to be done. So treatment for our own standards for treating the hepatitis B should be, the viral load should be lower because our patients developed cancer at very low viral loads, and the screening should also come lower.
Lewis, can I come to you on the thorny issue of guidance and obviously data, and really, when there is no data or less data in the populations that are actually providing the significant morbidity and mortality globally, how do we influence those guideline presenters? And before you answer, I just would highlight, we're talking about hepatitis B a lot, but it was very interesting to see, and it's embarrassing that, my team presented with Jeff in hepatitis C, the rarer subtypes of hepatitis C, the DAA therapy was less successful. And we really wanted to make that really a political comment to say that trials need to happen in sub-Saharan Africa, in Egypt, in all of Africa, because this is where hepatitis B is a big issue, and we're trying to push that agenda very much when we talk about hepatitis B new therapies. That's an aspiration. But what are your comments on this discussion that we're having, Lewis?
Yes, so I think, it's somewhat controversial. I think it's important for us to develop more evidence. I think there's a number of trials, for example, that would be important to do. One approach, for example, might be, as Edith suggested, dropping the threshold for treatment to, let's say, 200 international units, and saying, okay, what if we did a comparative study of current guideline care at 2,000 international units versus a cohort that we treated at 200 international units. Of course, that doesn't take away the fact that we have difficulty with doing viral loads across the board, but we have to start somewhere. And I think developing cooperative groups to try to address these questions in a systematic way is important. The other question that's maybe even further out there is the whole test and treat. Treat everyone who's surface antigen positive. And that maybe is even more controversial, but even having some pilots that we're testing these different modalities, I think would be important to help us get to, to improved evidence-based guidelines.
Okay, last couple of questions or comments from you. Thank you so much. It's been a really enjoyable session. I've really enjoyed contributing to this, but really listening to your expertise. So one final question for me, and then final comments from each of you. So from my colleague Jeff, who's really great, just generally, so few advances, and we're still talking about, vaccination as prevention and initiation of therapy. It's a horrible question, Jeff. How can we hook governments and NGOs to try and get this test and treat or point of care testing? Number one, I think this is an impossible question to answer, but in 30 seconds, each of you, what do you think about that comment? And if you have any final comments, just generally from our session, which has been really enjoyable. I'll come to you, Edith, first, if I may. You're muted. You did so well. We all did so well.
What's the government? I just don't know what we'll do to get the government to be in the driver's seats for this. When we were last in Egypt, last COLDA, we were listening to them and trying to learn how they did it in Egypt, that it became a government issue. So what is advocacy, it's just for us to move on and see how to convince the government, Ministry of Health and the NGOs to come in and help, so that if we can move from the tertiary hospitals to the secondary, even the local government hospitals, if the points of care testing can be near down to, and people should be trained to recognize these patients and send them on and attach them to treatment, things will definitely be better.
Okay,
So
okay, we're going to go very quickly. We've got 1 minute left, and I want to give the last word to, not me, Lewis. Professor Ashraf, any other comments about this big discussion about improving access very quickly?
Just in 10 minutes, in 10 seconds.
Seconds.
Yes, vaccination is already a program. Vaccination for hepatitis B is already programmed in our country. And for the hepatitis C virus, there is a big project helping other African countries having the problem of hepatitis C. We are providing the hepatitis C virus treatment for free for other African countries.
So firstly, I just need to thank you all. I need to thank the attendees for really good questions, just ticking off the comments. So number one, obviously we shouldn't forget the different trajectory in HIV co-infected with Hep B. We haven't really picked that up as much as maybe we should have done. Very nice comment from Alexander Stockdale about maybe a lower APRI for initiation of therapy, which we all agree with. Last 30 seconds and overall comments to you, Sir Lewis. It's been really great. Any take-home messages for our audience and attendees?
I think for the long term, really pushing the birth dose of hepatitis B vaccine. For the near term, thinking about hepatitis as part of a strategy for non-communicable diseases for our countries. We need to integrate hepatitis and liver cancer care into broader strategies for non-communicable diseases and what we would call chronic diseases in all our countries.
Thank you very much.